Good afternoon, everybody, and hello and welcome to the 13th Young IFSO Journal Club today. I'm really excited because today we have a joint venture between Young IFSO Latin America chapter and Young IFSO European chapter today. We have two fantastic speakers for you. We have Dr. Sebastian Arana from Mexico and Ms. Daniela Alcest from Switzerland, who are going to be talking to you about post-bariatric surgery, weight regain and appetite. So we've got a real good spectrum of talks for you today. I'm delighted to have my co-host, Dr. Eduardo Garcia Flores from Mexico as well, who's a bariatric surgeon and professor of surgery at Christos Health in Monterrey, Mexico. Thank you, Eduardo, for joining. And we also have Dr. Alexandra Naimark as well, who's joining us as a panel member. Thank you, from Russia. Thank you, Alexander. Just to remind you all, please put your questions for the speakers in the Q&A box at the bottom, and we would love to hear your thoughts and questions and interact with the speakers after their presentations. Also, to let you know, today's session is going to be recorded and will be available to view back at a later date on the IFSO YouTube channel and also on the IFSO Virtual Academy. So please do let your colleagues who couldn't join us today know so that they can catch up with it afterwards. Without further ado, I'll introduce our first speaker. So thank you very much. We have Dr. Sebastian Arana Garza, who's a professor of surgery and bariatric surgeon at the University in Monterrey in Mexico at Christos Health Hospital. Thank you very much, Sebastian.
Thank you, Rukana.
Sebastian is going to be talking to us about revision surgery options for weight regain after Roux-en-Y gastric bypass. And I believe we have his presentation to come now with the video. So please do think of your questions for him and put them in the Q&A box.
Good morning here in America. Good evening in the rest of the world. Thank you for the invitation to participate on this webinar. And I will try to be brief because this is a very complex subject. And let's go. So revision surgery options for weight regain after Roux-en-Y gastric bypass. I'm Sebastian Arana. I'm a surgeon from Mexico. And let's begin. So Roux-en-Y gastric bypass is still the gold standard. In the last statement from the ASMBS, we acknowledged the follow-up of Roux-en-Y gastric bypass in a follow-up for 5 to 10 years, with a resolution of diabetes in 84% and exit body weight loss to 10 years above 59%, which is a very good result for a procedure in the long run. But in the United States and in the rest of the world, it seems like Roux-en-Y gastric bypass it's getting a little bit ahead from the rest of the procedures, with the sleeve gastrectomy going up, and also we see this tendency of revisional surgery going up every day. This is the worldwide survey from 2016. Remember, after COVID, statistics are not very reliable. So this shows us a pretty good example of how revisional surgery is getting every year higher numbers. So why to revise a Roux-en-Y gastric bypass? We can revise it because it comes with weight regain or insufficient weight loss, some adverse effects like refractory Doppen syndrome or refractory hypoglycemia, or excessive weight loss with malnutrition. But what about patient behavior? Is there a keystone to success? Yes, it always needs to be the first approach in every patient. But if this is the most common cause of recurrence or weight regain, maybe yes, maybe not. But there's also lack of surgical standardization and lack of a follow-up standardization. So this must be addressed in the future. Well, talking about patient commitment. This is a paper from 2008 about a very about the adherence of patients to the follow-up after bariatric surgery, and some statistics and some criteria among the patient that can make a patient have a better or worse adherence to the program. Age, seal status, BMI, lateral status, and payment rate. All these variables may influence the amount of adherence a patient can have after a bariatric surgery. So, could be this also a problem of surgical technique? And we need to address some points about surgical technique, about pouch size, anastomosis sizes, gastro-gastro fistula, alimentary limb length, biliopancreatic limb length, and common channel length, and this new, well, not very new, but new criteria about total alimentary limb length. So let's talk about revision when surgical anatomy could be the cause. This is a systematic review of meta-analysis from 2021, talking about the different options we can, as surgeons, do to revise a Roux-en-Y gastric bypass. And the conclusions are that the best results on weight loss are from two types of procedures: a distal Roux-en-Y gastric bypass and a BPD/DS/SADIS option after a Roux-en-Y gastric bypass. These two kinds of procedures give the best results on weight loss. Endoscopic, endoluminal procedures, pouch resizing are good options, but not as effective as these two. Let's talk about the role of the total alimentary limb length in Roux-en-Y gastric bypass. And this is a systematic review from 2022. The paper addresses two topics, mostly that weight loss and malnutrition. And the conclusions are that a total alimentary limb above 400 centimeters and a common channel above 200 centimeters must be always the rule to avoid malnutrition and to have a better result in excess body weight loss. Quality of life must be our first goal, not to lose weight, but to give the patient quality of life. At all costs, avoid malnutrition and a very good patient selection, because we need to know that these kind of issues are multifactorial and needs to be addressed by the whole multidisciplinary team. And well, let's talk about our experience here in our clinic. We perform bariatric surgery in a third-level hospital here in Monterrey, Mexico, the largest city in the northern part of Mexico. And we will show you a little bit of how we manage this kind of patients. This patient is a 49-year-old female with a Roux-en-Y gastric bypass performed 17 years ago, with weight regain of 65% of excess weight loss, and type 2 diabetes with poor control on medication, and a gastroduodenostomy of 3.5 centimeters on endoscopy. So, perfect. First, we need to revise the length of every limb we have. So first, we need to measure alimentary limb. Be always cautious of the manipulation of the bowel until we reach to the JJ anastomosis. Then we address the biliopancreatic limb, also to measure it completely and try to get to the ligament of Treitz. Once we got to the Treitz, then we finish the procedure counting from the cecal bulb to the JJ. On this step, we can do it in two ways. First, count all the bowel from the common channel, or after we know how much centimeter we have on the alimentary limb, we can just measure the amount of bowel needed to complete 400 centimeters, because our tal will be not less than 400 centimeters. So we mark this measure, and then to avoid any problems, knowing which is proximal and distal, and then continue to count the rest of the common channel until we arrive to the JJ. Once we perform this, we can go to address the pouch. If pouch resizing is feasible, we will try to do it. Mostly if you have a dilated anastomosis, because pouch resizing is not like the best option for a revision, but it can also be complementary or can be valuable if we can do it. So we transect the gastroduodenostomy with a gold cartridge, and then we will perform a new gastroduodenostomy, trying to calibrate the anastomosis to a diameter of 2 centimeters. So we perform this with a mechanical suture, a white cartridge, and then in a normal fashion, close the defect with a strategic suture. After this step, we will do methylene blue test, because we cannot test the JJ anymore, and we remove the excess of jejunum and candy cane that can be still remaining on the bowel. Then we divide the alimentary limb from the JJ, and then we return to our mark to then perform a new distal jejunum anastomy to complete the distal ring-wide gastric bypass. This procedure can be performed in 1 hour and a half, but needs to be done with a lot of experience to avoid any misguided movement or any complication, because it's a technically not very easy procedure to do, so it needs to be performed by an experienced surgeon. So one thing we encourage for surgeons on this type of procedure is to have, we call it kindergarten napkins, is to draw every part of the procedure to avoid any complication or human errors in this measurement of lengths, because it can be very tricky sometimes. So this is an example of how we perform this planning for the surgery from the beginning to the end. The first, on the left side of the screen, we have the pre-op anatomy with an alimentary limb of 85 centimeters, a BP limb of 50 centimeters, in a common channel of 4.8 meters. So this gives us a total alimentary limb of 7 meters. So we need to distalize, and so we need to remove the alimentary limb from the JJ after or before we perform the resize of the pouch, and then we need to advance the alimentary limb 1.7 meters on the common channel to then do the new anastomosis, and then we have this new anatomy with an alimentary limb still of 85 centimeters, a biliary limb of 2.2 meters, and a new common channel of 3.15 meters. This new common channel plus the alimentary limb give us a total alimentary limb of 4 meters. So this is the way we approach patients with weight regain on a distal ring-wide gastric bypass. Remember, patients need to be properly instructed and properly explain about the procedure. And the perfect way to do it is to individualize every patient. This is an example of how we individualize every patient in metabolic patients to know which patient will benefit from distalization, also for metabolic control. For one very, very important thing to always keep in mind is that surgery is not always 100% of the answer. We already know that multidisciplinary approach needs to be done. So patient must be prepared before the revision and after the revision for the whole team, because most of the patients got lost in the process of the follow-up, and that was the main reason they regained weight and they lost the benefit from the first surgery. So we need to address every aspect of this multifactorial problem that is obesity to have a better result. A little bit of explaining about this topic is in Spanish. It translates safe corrective surgery. In Mexico, from the last 7 to 8 years, we have performed a process of standardization and certification from our surgeons. This is a very, very good thing that here in Mexico we try to achieve, to perform standardized procedures with a very good surgical practice to avoid complications. And thank you for your time. These are my contact information by email or social media. And let's see if the audience have some questions. Thank you.
Thank you, Dr. It's a great presentation.
Thank you.
Talk about one of the ways we can revise a gastric bypass. I think is one of the most common. Maybe in some countries do different things, but here we try to this kind of approach results in the Mexican population we treat.
Yes.
If we had any questions for the panelists, comments about the video, you do the things different. We want to discuss about how we do this.
I have a question.
Yes, Alexander.
Okay. Do you have a statistic about weight regain of your patients after Roux-en-Y bypass? How many patients have a weight regain, and what is long-term result when it starts to gain weight?
Great. I'm sorry I don't have a completely true answer to that, because most Mexican procedures are private. So our main concern about the follow-up is that we have less than 40% follow-up after 1 to 2 years. So that's difficult to have a correct answer to that. We speculate that we have around 20% of weight regain after ring-wide gastric bypass. Mostly in the last couple of years of the laparoscopic era, and we'll very experienced from surgeons around the country. And so I'm afraid that I cannot give like a completely right answer about numbers and statistics, because we lack of them. But after the revisions, those patients we can follow better, because those are better patients that are more concerned about the second surgery. And right now, after 4 years, more or less, we have very good results on weight regain and in diabetes control, because most of them are also with complication of diabetes.
Okay, you spoke about multidisciplinary team, but I hope you have it. And who start to work with these patients if he coming to you with problem of weight regain?
Who began the work with the patients?
Yeah, yes.
Oh, perfect. Yeah, all of our patients in both clinics, because Eduardo and I we're both surgeons in the same clinic. All of them, the first part of the process is approach of patients' habits and patients. The approach is more clinical because we cannot perform a surgery right away. We need to know why the patient got regained. If it was a problem of structure, a problem of portions, a problem of psychological matter. So we try to approach these patients multidisciplinary first, try most of the time to recover the procedure with a more tight follow-up around 3 to 6 months. And if that is not an answer, we try to perform the procedure. Mostly on patients with normal anatomy, because sometimes patients have very, very big pouches or very dilated anastomosis. So it's difficult for the patient to maintain restriction and portions. And we need to address also a little bit more right away, because we know that maybe the multidisciplinary approach will not be enough for those patients.
Thank you so much, Sebastian. We have a couple of questions from the audience. One of them is in Spanish, so I will leave that to Eduardo to ask you.
Yeah, the first question for Dr. Peña Rodriguez is, how do you calculate the distalization? What do you take count for the amount of small bowel you go to bypass to do the distalization?
Okay, we stick to the towel technique 100%. There's a lot of ways to do it. As some authors make calculation about 2/3 or percentages, and it's kind of difficult to standardize those kind of approaches. In our opinion, we stick to the towel technique. We always try to achieve 400 centimeters of towel. So we measure all the bowel, and after knowing the measure of the alimentary limb, then we try to advance the alimentary limb into the common channel to reach 400 centimeters and leave the BP limb larger at the same time.
We remind of the audience, you could type your questions in the question mark and we can make the question for the panelists.
I have a little questions about the total elementary limb and common limb. You told that when you count, it must be not less than 4 meters of total alimentary limbs. You always count alimentary and common, and you receive total alimentary limbs like this.
We always count the 3 bowels, and then after counting the 3, the alimentary, BP limb, and common, we divide the alimentary limb from the duodenostomy to advance it to the common channel. So we keep the same alimentary limb, we change the amount of common channel we got, and then we make the BP limb larger, trying to maintain always 4 centimeters of total alimentary limb length, but not less than 2 meters of common channel. We try to maintain the same approach as the papers from all the teams that are made this technique before.
Okay, it's why I asked, because you need 2 meters for total, for common limbs? Yes,
Yes.
it's minimum. Okay.
We had another questions. The question for it's how we minimize the postoperative mechanical obstruction, because we do a lot of new anastomosis, the arrangement of a small bowel. The doctor asked what we can do
Okay.
to minimize that.
Yes. For the matter of this webinar, we skipped some part of the surgery, but we need to reclose the open spaces in the mesenterium. Like we need to reclose Peterson, and we need to reclose the mesenteric defect to avoid any internal hernias. I do not think that this is like adding too much anastomosis. It's just one more anastomosis. This is part of the better part of this kind of technique. You only detach one and then rearrange it. If you perform a resize of the pouch with the same thing, you leave it the same. It's the same gastroionostomy. In our experience in both groups, we haven't got any complications derived from the revision itself. So, but if you move the bowel, you need to rearrange the defects just to be sure that everything is like safe.
Wonderful, thank you. Do we have any other questions from our panel? No. I think then, thank you very much, Sebastian. That was a fantastic talk and a great discussion. I think if it's okay for time, we can move on to our second talk for today, which is being presented by Ms. Daniela Alceste. She's a PhD candidate at the University of Zurich, and is also a member of the bariatric and metabolic surgery team at the University Hospital Zurich. She's a nutritionist by background and was also one of the finalists in the Young IFSO European Chapter Congress recently within our session. So Daniela, thank you very much for joining us. You're going to talk to us about association between parameters of ingestive behavior and body weight loss in patients a year after Roux-en-Y gastric bypass. So please, again, as Eduardo reminded the audience, if you have any questions for Daniela and also Sebastian at the end, please put them in the Q&A box and we can ask them in the discussion later. Thank you very much.
Hello, I'm Daniela Alceste. I'm from Venezuela and I'm currently doing my PhD at the University of Zurich, and I'm working at the Department of Visceral and Transplantation Surgery at the University Hospital in Zurich, Switzerland. Today I will present you one of our most recent works published last year at the Journal of Physiology and Behavior. The title is Association between Microstructure of Ingestive Behavior and Body Weight Loss in Patients 1 year after Roux-en-Y gastric bypass. To explain you a little bit what is this about, imagine that how you eat defines how much weight you lose. If this is true, we could have an enormous advantage in order to predict the weight loss when applying different interventions such as gastric bypass. But the problem is, how do we measure the how? So today I will show you one of our innovative approach to be able to measure the how. Metabolic bariatric surgery is one of the most successful treatments to improve obesity-related conditions. However, the underlying mechanisms of this success are not very well understood. Here we have on the right side of the slide the potential underlying mechanisms after Roux-en-Y gastric bypass. So we have gastrointestinal effects such as changes in gut hormones, gut microbiota, bile acid, etc. Then we have the systemic effects such as changes in insulin secretion, reward, body weight, energy expenditure, and then we have the behavioral modifications. Here, hunger, satiation, meal size, eating rate, and others are being affected by the surgery. So in these mechanisms we are interested in. The challenge is, how do we measure these changes in ingestive behavior in humans? There is an evident change of eating behavior after Roux-en-Y gastric bypass. And I believe that most of us see this in the clinical practice when patients report that their dietary intake changed after the surgery. The problem that we have is that we normally measure those changes with self-reported data, which is prone to mistakes. Most of the studies in humans have used indirect measures of a dietary behavior, which includes dietary records, 24 hours dietary recalls, or food frequency questionnaires. The problem with this is that the portion size are not accurate. There's a possible recall bias, and also is very time consuming for the participants and for the investigators. Then we have another approach, that is the direct measures, such as laboratory-based dietary studies, which measures with an universal eating monitor the dietary intake in a cafeteria-like setting. Also, people and investigators measures how much participants are consuming and what kind of food people are consuming. And rather than investigating how the food is consumed. Therefore, new methods to measure directly ingestive behavior are needed. Our group developed a new device. It's called the drinkometer. This is a novel device to measure ingestive behavior in humans. The drinkometer records in a high definition the weight of a fluid reservoir from which participants drink via a tube, as we could see in the picture. An ultrasonic sensor measures the height of the fluid to derive the density, and the drinking speed over time can be displayed as a waveform. Then we have the smallest unit of ingestion, that are SOGs, which are organized by verse. Information of ingestive volumes, rates, and duration can be then computed for the entire session, as well as the SOGs and verse. Then we obtain two sets of parameters. We have the macrostructure and macrostructural parameters of ingestion. The first gives us information of the meal size that the participants consume, the meal duration of the drinking session, the drinking rate, and the SOG number. Then we have PC-independent parameters, which are SOG duration, for instance, and also SOG the volume. And then we have the PC-dependent parameters, which includes the verse duration, number of verse, interverse interval, inter-SOG intervals. A validation study was performed in 2017 by a group, by one of our colleagues, Daniel Guerrero, which conclude that the drinkometer is able to detect differences in macrostructural parameters depending on different motivational states. This was done in normal weight participants. The second study using the drinkometer, it was in a prospective study before and after Roux-en-Y gastric bypass. We concluded that Roux-en-Y gastric bypass induced dynamic changes during the 1 year postoperative, while lean and obese control stayed the same. We could see on the right side of the slide that verse size decreased after the surgery, meal duration also decreased, numbers of verse stayed the same, and meal size also decreased by 55%. So now going back to our question, can how you eat define how much weight you lose after Roux-en-Y gastric bypass? So here we want to know, for instance, if a person that is eating slower with a smaller portions lose more weight than those that eat a bit worse, for instance, or what about those that they don't have any pause? So we aim with this study to explore a potential association between parameters of ingestive behavior and total weight loss in patients 1 year after Roux-en-Y gastric bypass. we designed a cross-sectional observational study in 24 adult patients 1 year after Roux-en-Y gastric bypass. So patients came to the hospital from between 11 a.m. and 2 p.m. with a 16 hours fasting state. We invited the participants to come, as I mentioned already, after 12 months of the operation. And we invite them to 2 study sessions, which were separated between 2 weeks. The purpose of this repeat measure was to assess if the parameters of ingestive behavior did not differ in this population within this short period of time, to see if these parameters were stable in these 2 sessions. The participants consumed a commercially available drink called Resource that is widely used in Switzerland. The appointments took place in a quiet room with 1 investigator. We could see in the picture how is the drinkometer set up, and each participant had a limited access with this from this drinkometer of 18 milliliters of the test stimulus. And we asked them to consume as much as they wanted until they got comfortably full or satisfied. Our results. Our same population was representative to the Swiss population undergoing Roux-en-Y gastric bypass, and as expected, there was a statistically significant weight loss after the surgery, after 12 months. And we also saw that weight loss correlated with the age of the participants. We also performed a pair difference test of the parameters of ingestive behavior between the 2 study sessions, as I mentioned before. So we saw that meal duration, drinking rate, number of sucks, and the macrostructure parameters did not significantly differ between the 2 study sessions. However, patients reduced their meal size after the 2nd session. This reduction might be influenced by a learning effect related to post-ingestive gastrointestinal effects experienced at the first study visit. Then we perform a correlation analysis between the parameters of ingested and body weight loss. We hypothesized that meal envelope size and meal duration might be associated with body weight loss 1 year after Roux-en-Y gastric bypass, but this was not the case in our study. However, we found that suck duration and inter-suck interval correlated with excess of body mass index loss and total weight loss, as we could see in the left side of the slide. So we have an example on the right part of the slide of 2 study participants. The one in green is a participant that had a higher body weight loss, meaning a lower BMI after 1 year post-operative, and on the red we have a study participant that lost less weight and had a higher BMI. We could see that the participant with higher body weight loss had a longer suck duration. So her suck, she took longer time to consume this liquid, and then we could see that she had lower intersuck interval. That means that their in between sucks was the time was shorter, comparing with the one in red. We are designing and carrying out different studies to better understand this phenomenon. For instance, we want to include male population. We want to also have a different surgical technique, for instance, sleeve gastrectomy, and also we want to see how is the behavior during a drug intervention instead of surgery, such as with GLP-1 receptor agonist. And of course, we also want to measure, or we measured already, the changes in food preferences and selection after Roux-en-Y gastric bypass that my group will present in IFSO World in Napoli this year. Some limitations of our study was that, first, our study lacks information of ingestive behavior of poor responders patients. So as I mentioned before, all of our study population had a successful or good response to the treatment, meaning that we could not see how is the macrostructure of ingestion of a poor responder. Then another limitation is that the laboratory setting of the measurements. This is something that is really relevant to see. However, when we apply direct measures, is always a limitation. Then we have the exclusion of a male population, and therefore we want to do in our next study the inclusion of this population. We have also the limitation that this is a liquid meal and this not represent the real life scenario. But it's important to see that we're measuring behavior, and with this we want to see if these changes occur, even if it's with a liquid meal or not. And the ingestive behavior was only measured postoperatively. Therefore, we also need to take into account to measure this ingestive behavior in a baseline measurements, and also with the inclusion of a control group without surgery. As a conclusion, macrostructural parameters of ingestive behavior, namely suck duration and intersuck intervals, were associated with the achieved Roux-en-Y gastric bypass weight loss 1 year after the surgery. Whether this preoperative and 1 year postoperative ingestive behavior can truly predict and account for body weight loss after Roux-en-Y gastric bypass, it still remains unknown. And a larger study population, which includes good and poor responders after Roux-en-Y gastric bypass, and very important longitudinal studies with a longer duration, 5-10 years, will be needed to ensure that these findings are more representative for the general bariatric population. Thank you very much for your attention. This is our research group. We are based in Zurich, and this was some years ago in our research retreat. I will be very happy for any questions that you have.
Thank you, Daniela. It's an amazing presentation. It's a very interesting topic. I know we had a lot of questions about it because we deal with this problem with our patients. When they say, I can eat less at the beginning, I want to eat more, and after 6 months, they came back and says, hey, doctor, I come back to the first month after my surgery, but had the good measure, it's amazing. Do you think to correlate your results with anatomy? Because we talked before about anatomy, maybe the suck interval changes because the pulse size, the anastomosis size, candy cane. It's a very good to correlate your results with anatomy, maybe an endoscopy or upper GI solo. It's amazing. Thank you for the presentation. Again, for the audience, if you got questions, use the Q&A box and we do the panelists.
I have one question. Can I ask? I want to ask you one question about this meter, the device that you are using. Like
Yes.
you are, I think, like in the gastric bypass patients or sleeve gastrectomy patients, we don't allow them to use a straw, like in the first month, because they insufflate air when they're sucking something out of the straw. So in this machine, is it possible that they can also ingest some air when they're trying to get the liquid out of it? Because it might maybe affect the results, because we usually don't want them to use these straws, but use a spoon or just drink it by natural sippings. So do you think that that might affect the results because they're insufflating some air into the pouch?
Thank you for the question. Very interesting point. And we do not have any complications with the device because of this factor. Also, I think it really depends on the use of the straw or not. some of our patients, they have no problems with drinking through a straw. So that's very interesting also to see how each center manage the patients and if they allow them or not to have the use of this straw. But for our patient, it's not a problem.
Okay, thank you. Also, can I ask
I have a
another one?
question.
Yes.
Okay.
Helen,
After that,
Go
I will.
ahead,
I
Helen.
will.
Go ahead.
Yes, please. Like, I just want to ask another one because in the gastric pouch and also in the sleep patients, there is also no fundus. So that might be a contributing factor for in most of the surgeries that they cannot ingest a lot of food and they don't have to, we advise them to drink water or liquids after they eat solids. Like when they eat solids, we want them to drink the water after like 20 minutes. When we call it the separation of fluids and the solids. This is a rule I don't know in our center. Maybe you are using the same thing. So this is, I think, another factor. So do you let your patients to do such a distinction, like to drink the fluids first and then eat, or do you don't care about it? Because I really want to learn about different centers because we do it as a rule. Like when you drink like 100 mLs of water, then we don't let them to eat on top of it because otherwise the stomach or the pouch will fill out very quickly. Do you think that is it sensible? Because the results of this study can also maybe give some idea about that.
Yeah, so it's interesting to see also because in the, for instance, when some of the patients, they were able to consume 1,000 milliliters, 1 liter, versus other participants that they just consume 200 milliliters or 100 milliliters. So it's very interesting to see how individual, it's very individual, this tolerance. Also, in the case of when they consume solid food, how much time they need to wait. I think during the time, during the progression and the time of after the surgery, patients also adapt to that they can tolerate better the needs of solid and liquid food. So I would say that it's very individual. We cannot generalize that for everyone will be 20 minutes ideal or 10 minutes or 30 minutes. We need to follow up the patients and see how is their reaction. But it's incredible to see that with the drinkometer, they were able to consume large amounts that I was very surprised to see it because you think, okay, the participant has only 1 year after operation, it will only handle very small amount, but it was not the case. So it's very surprising also. Also, other point is that the caloric density of this food, this liquid food was quite high. So they could also handle that very well for some participants.
Thank you very much.
Thank you. Sebastian, you have your hand up. You have a question?
Muy bien. Thank you. First of all, Daniela, congratulations on this paper. It's really amazing. Extend the congratulations to Marco. Marco's team is always way ahead of us in developing new things about how we can see bariatric surgery. But I get a question because I saw you leave the patient 16 hours on fasting, right?
Mm-hmm.
Did you think that this amount of fasting period may affect the results? Because sometimes patients who do lots of fasting above 4, 6, 8 hours got some discomfort, inflammation, secretions that get it stuck in the pouch. Do you think this may be an issue for the results?
Yes, so I mentioned that we, like in our team, there was a pilot study, and this pilot study consisted in expose the participants to different motivational states. So, for instance, the amount of hours fasting and not fasted period, also the amount of sugar of the concentrations, and in this paper we could see that the participants had a different behavior depending on the motivational state. So these 16 hours was done because we wanted to give this motivational part that the people were motivated to eat and consume the food. Okay, so if we will put the participants in a different fasting state, for sure, I believe that we will have different outcomes in the study.
Okay, perfect. Thank you.
Thank you for the question.
Got a question commentary for the audience. Dr. Toru says, after the surgery, due to the discrepancies how much patients we are with tolerate liquids, were these patients also studied with regards of the size of the pouch, the size of the anastomosis, as the doctor?
One second.
Doctor asked about if you study about the anastomosis pouch and the anastomosis size anastomosis pouch in this patient, because the difference between the liquid tolerance between the patients.
Sorry, I'm reading the question to understand it better.
Yeah.
Were there any anatomical studies done?
The commentary.
It's similar to what
Correlation.
Eduardo said at the beginning in
Yes.
terms of, had the patients undergone any investigations to make sure that they had normal pouch size, no kind of dilated or narrowed anastomoses first before you then studied them?
Yes, so the way that we control it is that all the surgeries and all the participants had to be, the surgery had to be performed by the same center. And within this time, we had only two or three bariatric surgeons. So they performed the same technique and for all the participants. So that's the way that we could control, but we didn't do any other tests after the surgery to control for this.
Okay. Yeah, it's definitely an interesting question in terms of how that then affects the eating behavior. I know Alexander's got a question before, if you don't mind. I just had one specific about your study itself in terms of, you found that people who had, was it better weight loss, were drinking smaller volumes, but more frequently. So did you measure the overall volume and compared it in terms of good versus poor weight loss at the end? So was the overall volume that they had over that period of time also less? Because perhaps if they were drinking more frequently, in the end, they had the same volume of the drink.
Yes, and one of our biggest problem was that all our participants had a very good response, like a very good weight loss after the surgery. And because one of the hypotheses or the theories that we have is because first is only the first year postoperative, and also because the inclusion criteria was very strict. And so coming back to the question, we cannot really, like, we saw that these participants losing more weight had this, they just drunk slower during this suck duration with shorter breaks comparing with the other ones. But to give an answer why they're doing that or how are doing that, or if it's because of a bad response to the surgery, is very difficult to know at the moment. So I cannot give you a clear answer at the moment.
Okay, no problem. Alexander.
Okay, it's a little bit the same questions, but a little bit maybe other side about when you evaluate the consumption of this. Do you find some correlation? Try to find between psychological factors, or maybe quality of life. Maybe you do something the parallel and it looks. Does it have an influence on that?
Yes, at the moment we're not including any psychological questionnaires or life quality of the participants. But this is a very important point because many patients, they complain about they're not happy with the weight loss, for instance, and they're not happy how they are eating, and that also can influence the behavior. But at the moment we don't do this in our study, but this is a very important point that we need to include in the future.
Do we have any more questions from our panel or any more from the audience? I think at the moment, no more from the audience. If there's any last minute burning questions, please do type them now.
I have a comment, not quite a question, because Aaron's question about the straw make me wonder, and maybe Daniela can work on that. This thing about the straw is more like common sense. It's not like anything published about if the straw gives us problems in the long run. But maybe this device may help us to achieve that. Like maybe, I don't know if it can get application for this device to measure if really the use of a straw may cause any problems on the pouch. Maybe it's another idea, because yes, all of us, or most of us, try to avoid the use of a straw because we think that it make the patient swallow air and discomfort, but it's nothing really like published about that. Maybe this device can help us.
Very good comment. So I will discuss with Marco, and Daniel is in the audience, so we can discuss with Marco about the topic, and could be a good research question.
Yeah,
Yes.
I think doing some
Because the
functional
bottom is-
imaging. Yeah, do it with a contrast swallow at the same time and see. There we go. Watch the space. Maybe next year we'll be presenting those results.
Yes.
You can actually measure the pouch size when she or he is insufflating, like ingesting it with the device. You can measure the pouch size via maybe MRI or something like that, like a dynamic study. Then it will be a very good research, and will prove that using a straw or ingesting very quickly might dilate the pouch. And this might also prove that that's why maybe the restrictive part of the bypass fails in like after 1 year. I think it's a very good research. Thank you for this wonderful paper. I really enjoyed it.
Thank you very much for the invitation. I really
You're
enjoyed
welcome.
presenting for you.
Perfect. I think on that note, I think that would be a nice way to finish our webinar today. So thank you very much, Daniela. Thank you very much, Sebastian, for some excellent talks and some really great discussion. I'm really grateful, Eduardo, for co-chairing as well, and Alexander and Erin for your insightful comments and questions on the panel. Thank you to all our audience for joining us. The next Young IFSO session is going to be at the IFSO Congress in Napoli, so please all do join us live, where we will have all of the chapters of Young IFSO present and presenting. And then we carry on with our future journal clubs 2 months after that. So thank you very much, everybody. I hope you have a great day, and we'll see you soon.
Bye-bye. Thank you.
Thank
you.
you.